today's lecture on the ECG. So it's all the action potentials just added up. And students always confuse it. It's like a single action potential because you come from 430 and that's where you set the action potential. But that's from a single cell. So you're just sticking electrodes on the skin and getting a signal. And that's the entire electrical activity of the heart. Let's see. It's the entire heart electrical activity. Now, here's the anatomical structures that conduct the electrical signal throughout the heart. And basically, this is Wednesday's lab. I always teach the material for the lab for the next unit. Okay? Because lab is right after lecture. It's too soon to have it right after. So this is the material I expect you to have down by Wednesday. Here's our four-chambered heart. And the first structure, right there, that's called the SA node. Sinoatrial node. I'm not going to write that out because I always just put SA. And that's where the heartbeat begins. With each heartbeat, it begins with the SA node. It's your number one pacemaker. So the signal starts in the atria, and it'll spread all the way through all the atria. They call these internodal pathways, these arrows I'm drawing. So let's make one distinction. Anything I call a pacemaker, the cells are very special. They have the ability to self-generate action potential. So let me make that distinction before I proceed. Pacemaker cells self-generate APs. And the reason that's important is if it doesn't do it, something else better, or your heart's going to stop beating. So these internodal pathways have no pacemaker potential. The signal is just spreading throughout the heart. First through the atria, then through the ventricles. So it's called internodal pathways because you go from node to node. You go from the number one pacemaker to the number two pacemaker, which is about right here. Let's call this the AV node, atrioventricular node. It's the number two pacemaker. The ranking of the pacemaker, since I have a 2, it's the second strongest. The strongest pacemaker will command the heartbeat, the heart rhythm. And you always want your number one pacemaker to be the one that's operating the heart. And so that's the sinoatrial node. What you should know about that, I'll write it over here. The number one pacemaker, it could generate 80 to 100 APs per minute. Now your resting heart rate on average is slower than that, which tells you there's some autonomic dampening effect. So if that's the strongest pacemaker, the number two pacemaker can generate 40 to 60 APs per minute. So if anything poops out with number one, number two should take over. That's kind of pecking order here. You spread the signal to the AV node. Now the signal has an opportunity to spread down to the ventricles. And it spreads down the septum, okay, straight down the middle there. There's a special bundle. I'm going to draw it right there. It's called the bundle of His. Sometimes it's just called the AV bundle, but I tend to call it the bundle of His. So I drew a dot and a line. The dot is the AV node. The bundle is the bundle of His. Now the thing about it is, you're converging all of these pathways onto one pathway, one bundle. And that tends to slow the signal down, okay? Like a traffic jam when freeways merge or something like that. So because of that, the conduction of the signal going from atria to ventricles is delayed. So because of the bundle of His, you observe a delay at the AV node. And that's good, because if you recall, the atria contract before the ventricles by design. This is the design. You have a delay of the conduction getting down to the ventricles. The atria can finish contracting first, finishing the end of inflow. So when you have this delay, then the signal spreads down the bundle of His. It branches. It's right here. There's two bundle branches. There's one on the left and one on the right. So those two are the left and right bundle branches. Now you reach the apex of the heart, right? Remember, the apex of the heart is the tip of the ventricle. Once the signal reaches the tip of the heart, the apex, it can go up the sides of the wall. And as it goes up to the sides of the wall, it gives off all of these fibers, which are modified muscle fibers called the Purkinje fibers. I said those are the ones you can identify for extra credit. Purkinje fibers. Your Purkinje fibers are considered your number 3 pacemaker. If they have to, they can self-generate action potentials at a click of about 20 to 40 APs per minute. Now the whole AP is action potential. Think of an action potential as being one heartbeat. If at any one of these 3 pacemakers, say the number 1 or number 2 or number 3, each pacemaker, when it generates an action potential, that depolarization spreads through the whole heart for one heartbeat. Okay, so every time you feel a pulse, your pulse rate, it's symbolic of one SA node firing through the whole heart, making the whole heart contract. Okay, it's a pretty remarkable thing. So it looks like you got 2 pacemakers up in the atria and you got 1 down in the ventricles. Okay. And look at this very tenuous connection between signal getting from atria down to ventricles. It's a singular connection, isn't it? It's right here. What is that? What I circled? Identify. Bundle of His. That one little bundle, if that gets blocked, they call that heart block. Well, I'll have a slide on that later. Okay. All right, so the important thing to note on this slide are all the nodes. All these structures listed here. I listed them in order of how the signal spreads throughout the heart. And what we're going to learn today is we're going to look at the Ecg trace. We're going to see how it spreads through these different structures. And it's your job to know which part of the cardiac cycle is represented by which part of the trace. When I say trace, it's that classic thing everyone sees on the side of an ambulance. This thing, right? So to get that view on a subject in a lab, I mean, even students can do it. It's not very hard because it's just a skin surface electrode, and I'll show you how to apply them correctly. A skin surface electrode is like taking a picture of the electrical activity of the heart. Just much like you take a photographic picture of anything. They say, for example, of a sports car. And when you take a picture from a different view, whether it be the top or the bottom or the front or the back, it gives you a different view of the same race car, for example. I mean, it's the exact same thing as taking a view of the electrical activity of the heart. You're just trying to get a sense of how it's spreading through the heart, and to the trained eye, you can see different things. For you guys, I just want you to know which ECG components is which part of the cardiac cycle. Okay, you guys are just barely, okay, do I understand the cardiac cycle? That's where you guys are at, right? Now you need to apply that to what you can see in the lab and say, oh, okay, I can look at that trace, and I know what's going on in the heart. That's what we're trying to get you guys. Now, the standard clinical procedure, which we're not doing, is called a 12 lead. A lead, well, is basically one view of the heart, okay? And you can put electrodes, this kind of blows my mind, you can put electrodes on your extremities, and you can get a view of the electrical activity of the heart, okay? You can put electrodes, of course, along the chest wall here, and get a different kind of view. So a 12 lead are 12 views of the heart, and there's a boy getting a 12 lead, and here are 12 views of the heart. We're only doing one lead, lead number 2. It's kind of a classic one done in different labs. Don't try to do anything else besides lead 2. Sometimes you get paramedics in here and they think they know what to do, and they try to do a different lead, and it doesn't work for our equipment. Stick to lead 2, stick to our procedures for Wednesday's lab. So here's why we have 12 leads. 6 views. This is a frontal or coronal section, okay, that view of the heart. These 6 with these leads here, you're getting a transverse view of the electrical activity of the heart. So again, we're doing lead 2. That's this one there. So we put an electrode there in the ankle, wrist, ankle, that's our lead. So as you can see here, electrodes, it's like positive and negative leads. There's a picture from your procedure. Positive lead is the red lead, okay, right there. And the negative electrode is the white lead from there. So it's negative to positive, okay? And the reason why it's negative to positive, because when your signal spreads, it presents a deflection. So let me kind of explain that. Let me use this. Kind of how I draw out the ECG. So, any deflection, any bump or spike, in the lead, what it means is the depolarization is spreading in the same direction as your lead. That's why you see something. Any deflection in your lead means the depolarization. Remember depolarization, repolarization, that language that was used in action potential lectures? That's what we're talking about. To me, this always means the same thing as action potential. Okay. It means the depolarization is spreading in the heart the same direction as your lead. Now we're doing lead 2, and so you can see the approximate angle and plane in three-dimensional space that's in. Here's your heart, and that's all it means. Now, this flat line, they call that the isoelectric line, or baseline. That simply means, if it's a flat line, all it means is the depolarization is spreading perpendicular to your lead, so you're just not going to see anything. Isometric. The dipole is spreading perpendicular to your lead. So you just can't see anything. It doesn't mean nothing's happening, it's just you ain't seeing it. Now if it's a complete flat line, that means you're dead, right? Everyone knows that. So here's kind of the circle of views. We're just doing lead 2, negative to positive, so that's why I put the red arrow there. Just to give you an idea. That's our lead going through the heart. Here's all the structures that we have to monitor as we study it. Okay, so we're doing lead 2. So that's what I wrote on the board, is what I said there. When the wave of depolarization moves toward the positive lead, there is a positive deflection in the recording. You just see something. And you have to know what those are. So we call these the Ecg components. So as we go through the components, I want you to relate it to the Wigger's diagram that we studied last time on Friday. All right, so what I did was one day students were taking a test, and I just was playing around with the BioPack here. And this blue box here, this is our physiology hardware. What you guys are going to get, we keep these big black cases, and it has a laptop, and it has our hardware. And there are some technical difficulties that happen in this lab. A lot of times, the laptops don't work. You can't get it started. You can't, maybe it updates when you're trying to do the lab. All kinds of frustrating things can happen, so I want to throw that out there. Just come to me if you're having problems, and we'll see if we can get you set up with a new unit if you have technical difficulties. But what I was doing, I just took my own ECG, and I didn't do it doesn't look textbook. And I thought that would be a good thing to teach from, because when you see your subject's ECGs, it's not going to look like the textbook. And you're going to, it's a little bit more difficult to see. So I thought if I leaned you in on mine, we get a better idea of how to look for things. So what I did was I highlighted in blue. Well, what you'll do is you'll highlight different traces, and you should really appreciate that you get to use a computer to do this. The old school ECGs, it's like a piece of chart paper and ink pen. And the chart paper is graduated. It's got all these little boxes, and each box is like 0.02 seconds or something, and you have to count the boxes. It's very frustrating. But this, you can just click and drag, and the computer will tell you how much time has elapsed. Okay, it's a much easier tool to use. So as I go through the ECG components, the knowledge you're supposed to have is which part of the cardiac cycle are you looking at? That's the skill set. Which component, ECG component, represents which part of the cardiac cycle? And in the lab, you'll just try to kind of measure all these ECG components. So I want to start with this P wave here. So what I'll do is I'll just kind of use the color red. Starts off with your isoelectric line, and the P wave is this first hump, like I highlighted in blue there. P wave. Then it goes. Well, the rest of it is P. Use letters Q. That tip is R. R wave, then S, then a flat line, then T. So P, Q, R, S, T. Just that first wave is the P wave, and well, that represents atrial depolarization. So atrial depolarization causes, systole, contraction. It's not contraction, but it definitely causes it immediately. P wave is atrial depolarization. It causes atrial systole. I'll write that. Causes atrial systole. Do you remember when that is? Well, think inflow or outflow. Did it happen during inflow or outflow in the cardiac cycle? It happened towards the end of inflow. Do you remember that? It was like the last 30% of the filling, and then right after that, you started to go into ventricular systole. So start thinking cardiac cycle. This is end of inflow. So anyways, the SA node, that's what we're talking about here. So on the picture there, the yellow represents the signal spread, and it starts at the SA node. That's your number one pacemaker. SA node establishes, if I can spell this morning, establishes your normal sinus rhythm. That's kind of what you want to call it. I guess think of this as the beginning of the ECG. That's usually where we start tracking it. Well, anyways, what I did was I took the Wigger's diagram and I just put a big box around the P wave, and I put it through the entire cardiac cycle figure, so you can kind of see, oh yeah, that's the end of inflow. Now, if you're a little behind and you haven't been studying the cardiac cycle, this is going to be hard for you to grasp. So first master cardiac cycle, then start to figure out the ECG components. Well, the next thing we have students measure is called the PR interval. You measure that by highlighting the beginning of the P wave all the way up to Q. So let me just illustrate that by coloring it red. Isoelectric line, so the P wave, then all the way up to right there. QRS. So again, this ECG component, let's call this PR interval. That segment right there. Okay, this is where the signal has spread throughout the entire atria, but it's that minor delay before it gets down to the ventricles. So the PR interval represents a conduction delay from atria to ventricles. It's a little pause. The pause is about 100 milliseconds. Delay of 100 milliseconds. That is just enough of delay for the atria to finish their systole to just top off the ventricular filling. Because you want those ventricles full before they start to contract. Okay. That's what I say here. So now what you've reached is you get all the way through the atria, and now you're at the AV node. Okay, so this is where you observe this delay at the AV node. I should note that. I already did, but let's write it again. Observe this delay at AV node. Remember, the delay is occurring because of the bundle of His. The signal has a tough time getting through that traffic jam, but you observe the delay at the AV node. Okay. So the delay is caused by the bundle of His, but you observe it at the AV node. That's kind of how we stated. So it's the time between inflow and isovolumetric contraction. A very brief time there. You know, another way you can measure this delay is the PR segment. The thing I drew on the board was the PR interval, but the PR segment is this. See, that's that little segment right there. PR segment also represents this conduction delay. However, sometimes it's hard to see it. Okay, like mine, it's hard to see because like there's a little squiggly noise there. Mine will be like right here, but it's hard to see because there's a little bump there. So it's not a true flat segment. So that's why we say for students, if you want to measure the delay easily, it's easier to see the beginning of the P wave and just go all the way up to the Q. So that's the only reason why we tend to measure the PR interval instead of PR segment. But they both represent that delay, that brief time before the signal gets down to the apex of the heart. Okay. So pretty much we've gone all the way up to inflow, up to the end of inflow. There, so I highlighted where the PR segment, where I would have highlighted it on my own ECG graph. Okay, so there it is, the PR segment highlighted. We're just right at the very end of inflow there. So this is a good time to talk about heart block, because now the signal spreads from atria down to the ventricles, and if there's a problem getting down that bundle of His, it may show as what we call AV block or just heart block. It could be partial or complete. And we do expect students to know the difference between first, second, or third degree block. Now, if they call it AV block, you've studied the anatomy of the heart. What do you think that A stands for? Atria. The V is ventricle. So the block is a block between signal getting from atria down to ventricles, right? So well, that makes sense. So let's go through the degrees of block. So the top Ecg trace is normal. And do you remember how I said, if you think we have a computer, if you're on chart paper, you have those like little boxes that you would have to count to figure out how long it is. You don't have to worry about that. Okay, well, anyways, first degree heart block. It's pretty much just a longer than usual PR interval. Usually if it's greater than 0.2 seconds, we're thinking, oh, that's a little bit too long. There's usually no concern there because you can usually have a normal sinus rhythm. The whole thing here is if there's a block, is there enough cardiac output to sustain blood pressure? Okay, that's what you're worried about here with any kind of block. And to my knowledge, I don't think there's any clinical emergency for a first degree heart block because the signal's getting down okay. Okay, when we get to second degree, it's a bit of a concern because you're skipping a heartbeat. Let me read what it says here. This is called a partial intermittent block. The ECG, what it'll show is the PR interval gradually gets longer and longer, and the AV node completely fails. PR interval gets longer and fails. And what you see is that there's no R wave, that sharp spike, which represents ventricular depolarization. No R wave. And basically think of it as your heart skips a beat. Okay. But this is probably okay too, because there's enough getting through to where you probably have enough cardiac output. Okay. This one down here is a complete block. It could be problematic. So the third one, third degree, is not a partial, it's complete block. Complete AV dissociation. So let's think about it. The signal is not getting down to the ventricles. What's the number 3 pacemaker in the ventricles? Purkinje fibers. So they have to take over. So they're just gonna like make their heart ventricles contract weekly at their own rate. But then the SAAB node, they're gonna like be making the atria contract on their own time. So they're not gonna be in sync at all. And how that shows on the ECG is random P's, random Q's, or random P's, random R's. Okay, there's the P's, but then the R's, they don't match up. There's no rhyme or reason to it. Okay. Random P's, that's the SAAB node causing the P wave. And then you have random R waves, because the Purkinje fibers have their own pacemaker potential. So I'll be able to look at a trace and figure out which kind of block it is. Okay, we're going to move on to the bundle of His. So if the signal does get through, what you see in the picture there, they're using yellow for depolarization. So what's red? Repolarization. So while the atria are repolarizing, the signal is spreading down the septum between the ventricles. When the signal reaches the apex, it creates the Q wave. So let me draw that on the board. So you got P, PR interval, then the little down deflection is the Q wave. Just that. The dipole, the polarization, spreads down, bundle of His, down the interventricular septum of the left-right bundle branches, then down left and right bundle branches, within the interventricular septum. How many bundle of hisses are there? One. How many bundle branches are there? Two. Now, students tend to forget about the bundle branches. I don't know why. Think of it this way. How many ventricles are there in the heart? Two. There's one on the left, and there's one on the right. And that's why you have a left and right bundle branch, because it's going to go to each one. But for now, they're both contained within the septum. All right? So you get to the apex, you start to spread out the sides of the wall, but basically you get to the apex, get to apex of heart, CQ waves, what I'm writing here. And what you, well, this is just prior to systole, just prior to isovolumetric contraction. Just before systole. Not quite there yet. All right, so I wanted to show you this picture of the heart valves. And I wanted to show you this outline here, which is just the fibrous connective structures that contain the valves of the heart. Because, well, there's a reason why the depolarization spreads down the septum and not straight down to the ventricles. I didn't realize this for like decades. Like, you see how the depolarization spreads all the way up to there and it just stops? Like, how come it just doesn't go down the whole thing? Why does it go down this little bundle of his there? And the anatomical reason for that is because the fibrous ring structure of the valves, connective tissue doesn't conduct the electrical signal. So it's forced down this tiny hole, and that is the opening for the bundle of His. Okay. Connective tissue of valves doesn't conduct APs. Electricity doesn't want to travel down it. So you force the entire signal through the tiny opening for bundle of His. Force the signal through one bundle of His. And the other anatomical importance of this is you're depolarizing the septum first. So depol, interventricular septum. I should write the whole thing. Depolarize interventricular septum. That's also important. Think about it. You want to squeeze blood out of the heart. When you just stimulate the muscle in the middle, can you squeeze? Yes or no? What do you think? No. This is great because now when you get down to the tip, you can start to squeeze from the bottom up. Okay. It's like a tube of toothpaste. What happens if you squeeze a tube of toothpaste only from the top? When you get some toothpaste out in the top, what about all the toothpaste in the bottom? You ain't getting that out. unless you squeeze from the bottom. So it's the same thing for the heart, squeeze from the bottom up. Now the signal will spread up the sides of the wall and depolarize the entire ventricles. So what we see on the ECG when the depolarization spreads throughout the entire heart wall of the ventricles is QRS complex. So let's go isoelectric line P, then when you get to Q, QRS. QRS. It represents the ventricular dipole. This causes ventricular systole. So systole is going to happen a millisecond later. And I haven't been noting the times. I have them on the slide. You're going to measure them in lab. That's why I'm not really mentioning it in the lecture. I just want you to get the concept down. But let's comment on something. The P, the Q, the R, the S, and the T. Notice the P and the T waves. The waveform says something. They're just kind of like long hills. Okay. But the QRS is a sharp spike. So what does that tell you about the speed and force of contraction for the ventricles? So what it tells me is it's faster and stronger. So what's happening is the depolarization is spreading up the sides of ventricular walls fast via Purkinje fibers. And you have to say it just like that, Purkinje. Well, you'll be able to see them on your heart today, I think. Okay, so here's QRS, and it's just prior to it causes the systole. So this is right before isovolumetric contraction. And okay, let's talk about events after depolarization when the ventricles are actually contracting. And after QRS is something called the ST segment. QRS. That flat segment between QRS and the T wave, boom, right there. It's called the ST segment. This is important to measure. This is when the ventricles are in peak systole. When ventricles are in peak systole. Now the ECG on the Wigger's diagram is not drawn to scale, but I put a big box around ST segment, and you can see it is during the peak systole. And so if you're having a heart attack or any kind of cardiac issue, you may see an abnormality in the ST segment. If you have a depression, they call it below the line, that may indicate ischemia. Ischemia is a lack of blood flow. You should know that. below the line. What line? I guess the isoelectric line, quote unquote. Well, anyways, below the line, the depression of the ST segment may equal lack of blood flow. Maybe the patient is complaining of chest pains, just overall uneasiness. Maybe the heart muscle is not getting the blood. Maybe there's a blockage, something going on. And ST segment elevation above the line. Elevation. That may mean injury. We call it acute myocardial infarction. Heart attack. You don't call it heart attack. That's what lay people call it. You call it acute MI. Okay, that's the clinical term. And I had a student who was a paramedic in the field. He brought this in. I was like, oh, can I use this? Well, anyways, this is a 12 lead. Can you see lead 2? Lead 2 is, it's over here. I blew it up for you. It's, well, I'm pointing to it. Do you see how like the segment runs right into the T wave? You know, so that's why you suspect injury. I'm sure it was confirmed heart attack when you got into the hospital there. All right, so then QT interval. Well, let me draw it first, like I've been doing it. So it goes, when you're up to Q, I'll highlight the entire QT interval in red. Here's Q, R, S, all the way to the end of T, all that. And what that is, it represents all of systole, the entire systole, not just peak systole, all of it. QT interval represents all of systole. There it is, the entire QT. It's the whole big hump, right? All of systole. Okay, part of the lab for Wednesday, one of your subjects has to exercise for a brief period of time. So I want to say that, you know, figure out who your group's going to be. Maybe use the same groups today as you do for Wednesday. But whatever the groups are, someone exercises. I want someone to come dressed to work out. Okay, if you're physically able and you can do it. That's great. You know, I should also mention, someone has to lie down in this room. So maybe it'll help to bring a yoga mat or something for your subject. You have to lie down somehow, just saying. So think about that. For the exercise part, without even looking at that, maybe that doesn't make sense to you. Do you think your heart rate's elevated? Okay, I don't have to ask these people now. Your heart beats faster and stronger. Okay, look at the QT interval. As the heart rate increases, what happens at QT interval? It decreases. That makes sense, right? So each systole, it's contracting faster and stronger. Okay, so you're injecting more blood with each heartbeat, in addition to elevated heart rate. And so you should measure that in your subjects. Okay. nurses with elevated heart rate during exercise. Now, we're not going to really get too intense. You only have to work out for a couple of minutes. Since we're doing it, you know, your heart rate max, just based on your age, is 220 minus your age. So if you're 20 years old, 20-year-old college freshman, that's your heart rate max. What we say is that you should be working out between 70 and 85% of your heart rate max. So you can do the math, right? That's your zone. Okay. You know, sometimes I go on runs, and I have this guy that I jog with. We drive each other crazy because we push each other to our max. I have one of those Fitbits that I can track my heart rate. I was running at 97% of my heart rate max for most of the run. I was like, oh my God, I'm gonna die. There's this fitness center, it's a chain, it's called Orange Theory. You guys heard of that? Yeah. The principle of that is they want you in excess of that for a certain period of time, real high intense. And the theory is you increase your oxygen depth so that you burn more calories during your recovery. And that's true. So there's some credence there. You really put. Now, I don't want anyone to get that high, okay? They don't have to. But just kind of, I mean, for young, if you get at least up to here, right? 110, 120, that should be pretty good. You just want to see QT intervals shrink a little bit. That's all you're going for. Don't go for too much more. All right. So I have a few more slides to get through. I think I want to stop here, though. I want to make sure you guys have plenty of time for today's dissection. So let's break now until 8:45. We'll be all ready for our dissection. I'll go pull the hearts out.